Hey, everybody, and welcome to today's live stream. Thank you for joining us. So excited to have Patrick Tino here with me today. We're going to be talking all about Rehab Summit, which is coming up soon in Orlando, Florida, August 7th through 10th. We're so excited to be bringing together some really amazing professionals and experts in the field to talk about some really pressing topics in rehab and the future of the profession and how that impacts, a lot of the clinicians out there that are working day to day clinically with skills, techniques, interventions, new evidence-based practices. But today, again, I'm joined by Patrick Tino. So happy to have you here with me today, Pat. We're going to be talking about some of your sessions that you're going to be teaching at Rehab Summit. The first one that I want to dive into is your session on techniques and strategies for differentiating central and peripheral vertigo. So Pat, welcome. The first question I have for you today in regards to this topic of vertigo is, how are peripheral and central vertigo different? I will start with that, and then I want to dive a little bit deeper.
Sure, that's great. Evan, I'm pleased to be here. Thank you. This is a very big pleasure for me. In order to really differentiate vertigo and to treat it effectively, you have to evaluate it. And not only do you have to evaluate vertigo, but you have to determine whether the vertigo is arising from something in the central nervous system or something in the peripheral nervous system. And so when someone has a peripheral cause of vertigo, typically it's going to be a condition called BPPV, or benign paroxysmal positional vertigo. Essentially, one only feels symptoms when they move their head in either up and down manner, or they diagonally move it, typically when looking up at a ceiling or in the shower, or looking down in a cupboard or in the dryer to retrieve clothing. Additionally, one can also get a condition called peripheral vestibular neuritis. And essentially, most people are familiar with a condition called Bell's palsy. So Bell's palsy is caused by a virus that attacks the seventh cranial nerve, which is the facial nerve. And it basically just kind of limits the ability to close one eye and gives you a facial droop. And typically that's a fleeting symptom, and it relieves on its own. With cranial nerve number 8, the vestibular neuritis attacks that nerve, and so it's quite different from the other condition. And essentially, it's three main things to look for. You have to be looking out for an individual who has complaints of vertigo not related to head position. They last 48 to 72 hours. And then they'll have, when they walk, they'll typically list or lose their balance to one side. That's the side that's usually affected. And then thirdly, when they move their head at a particular rate of speed, objects in their environment, street signs, name badges, TV items, and things looking at the TV become blurry. So that's peripheral. And now central vertigo is a little bit different. So with conditions like that, you're going to be looking at, like a vestibular migraine, or a condition related from a stroke to the part of the brain called the cerebellum, and things like that.
Of course, and I a question that I want to kind of dig a little deeper on there, and I think you did a really great job of differentiating the two. But as a clinician, when a patient comes in for the first time and they're having some of these, vertigo-like symptoms, and you're trying to sit down and look at it and evaluate and assess whether or not you think it is peripheral central, are there key indicators that you're looking for between the two presentations to kind of really guide your plan of care and where you're headed with treatment?
I am. So I'm very big on something called the visual system. So basically, when you look at your patient, or you look at anybody for that matter, their eyes are centered right within the orbit, and the eyes are not going to volitionally move to the right or to the left or up and down on their own. So when someone has a central vestibular problem, typically those symptoms are less severe in terms of nausea or vomiting, or what we call the beating of the eyes, which is nystagmus. And so when I'm looking at that system, if my patient has a eye movement where I'm noticing the eye moving, for example, to the right at a particular rate of speed, then I'm going to be thinking that it's going to be coming from the left vestibular nerve. Now, compare that to somebody who may have a condition where their eyes might be beating upwards or downwards. We call that upbeating or downbeating. That's going to be more from a central nervous system viewpoint. And that can be from multiple sclerosis, that can be from a traumatic brain injury, that can be from a variety of conditions related to, some damage to the brain or brain stem.
Yeah, of course. And I want to take a second to kind of separate, peripheral versus central, and talk a little bit more in terms of, treatment strategies and interventions you might call upon. So starting with central vertigo, you talked about things like vestibular migraines, cerebral strokes, other conditions that fall into that bucket. What kind of targeted strategies or interventions that do you primarily call upon to help with some of those symptoms and help towards your functional outcomes?
Good question. So, if someone has been identified as having vertigo resulting from a central nervous system problem, such as a vestibular migraine or maybe a stroke that affected part of the cerebellum or even multiple sclerosis, they're going to have problems with their balance system, the proprioceptive system, um, coordination. So my treatment strategies are going to revolve around doing particular activities where they might be standing on a compliant surface, which is something that might be thick rug or sand, grass, wood floors, and then I'm going to have them narrow their feet or widen their feet to make it more challenging. And then I'm going to have them, close their eyes or keep their eyes open. So I progressively make it harder, or if they're having trouble, I may regress and make it easier. Now, if somebody were to have a problem with peripheral vestibular problems, and now I'm going to be doing another type of treatment parameter, and that's called adaptation. So you heard me speak about earlier with the eye beating, we call that nystagmus, and that's tied into a reflex in the body called the vestibular ocular reflex. And basically, the VOR allows a person's vision to pick up things in the environment while their head is turning. So most things in life, we have to turn our head. And as our head begins to turn at a particular rate of speed, that's typically 2 hertz or greater, things become a little blurry if there's damage. So my treatment strategy is VOR training specifically for that. We call that ×1 or ×2 viewing. My patients love to do that. And then the other parameter of exercises are called habituation exercises. Essentially, habituation exercises revolve around finding a movement that causes symptomology, nausea, dizziness, a little unsettled feeling. And then as one gets repeatedly subjected to that particular trigger, their brain adapts to that. So the best example is, down here in Tampa, Busch Gardens or any amusement park, you go on a ride that, involves rotation or quick up and quick down. Well, as kids, we love that. As we get older, not so much. But when the vestibular system is damaged and you actually have people go and you do things like that, for example, it helps to hone or improve that system.
Yeah, and I think it's a great analogy used there, considering we will be in Orlando, right across from some of those rides and stuff, and how that does impact the vestibular system. You mentioned, and I wanted to touch on this. You mentioned a part of in that chat that I wanted to kind of go a little bit deeper on. So you talked about like different surfaces, whether it's like grass or stable surfaces, could be sand, things that you might integrate into your treatment plan to help with some of these individuals. And I guess that's where I wanted to go with this individualized care. I know that's something that you've talked a lot about in your session, and something that I find very interesting, which is, every patient is different, right? Has different presentations, has different activities that they want to get back to. So how do you bring in that individualized component of care into what you're doing? And are you looking at letting your patients kind of guide where you want treatment to go? So yeah, if you could kind of speak to that.
Yeah, it's a great question, and essentially, what I like to do is I have I've been teaching vestibular courses for about 12 to 15 years now, and essentially I developed this model where it's ADL related, task specific. So I'm asking my patients what activities they want to improve upon, whether it's a hobby like playing tennis or or working in their garage doing some woodworking, or whether it's doing their job, which involves sitting at a desk and looking at multiple screens. So I tailor my exercise program to, number one, what their functional goal is. I keep it fun, because vestibular training is different than if you're going to build muscles in your arms or your legs and you do exercises with weights. Vestibular training specifically involves a lot of head movement, a lot of trunk movement, a lot of putting your feet together, standing on a foam pad, standing on an uneven ball, sitting on a ball, moving the ball. It's challenging, but if you make it fun, so if you build an exercise program where the patient or client feels that they're actually strengthening their muscles, but my other motto is you respect the constants and you adjust the variables. So the constants are, if you're doing something where you have to improve the adaptation or the VOR reflex, you have to have the head moving, and you have to have it moving at a particular speed in various directions. Versus if you're doing a habituation exercise where maybe somebody is going to be in the kitchen and they have to work at the stove and work at the refrigerator, so they have to turn around quickly. So I may have them walk 5 steps, turn around, walk a different direction, turn around, walk back. And so the constant turning and moving, maybe even walking in a figure 8 pattern, maybe so it's individualized in respect to what makes them better, number one, and what they like to do.
Yeah, and with habituation, exercises, you talked about that can recreate those symptoms for the patient. And so when you're introducing that in the clinic, I'm sure that there's probably a fine balance to, understanding you have a certain amount of time, treatment time. You want to be able to, address those functional goals, whether it is, turning around, like you mentioned, in the kitchen, or performing some of those quick movements. So you're kind of, I guess, simulating those symptoms, and then you're expecting that the patient's probably going to, then need a period of some sort of readjustment to kind of get back to baseline. So I guess in that, how do you balance out your treatment sessions, right? And knowing that, hey, I could stimulate this symptom, and then this patient could be done for the day. So I guess kind of how do you grade that through your treatments?
Yeah, that's very good. So to answer the first part of it, basically I try and make it setting specific. So if you're in a hospital, you're limited to working in a patient's room or the hallway. If you're in a skilled nursing facility, same thing, room, you may have a gym. If you're in the outpatient clinic, you have to relate it to what you have available in the outpatient clinic. And if you're in a home, you've struck gold, because now you're working within the patient's home environment. So that's the first thing. But, for reimbursement purposes and documentation purposes, we have to have an outcome measure, or something that the insurance company can look at as a baseline. And so the best thing that I like to use is something called the MSQ, which is the motion sensitivity quotient. Essentially, it's a battery of 16 movements that involve the head, neck, and trunk. And now a therapist doesn't have to do all 16 of those. The therapist is obligated, to really pick the ones that are most functional for that patient. Let's say you pick 7 of those, and then you score the patient in their symptomology in terms of frequency and duration and intensity of symptoms. And then you build a plan and you do those exact movements over and over. And then you retest them maybe 2 weeks later. And then you give them a score. So many outpatient clinics have especially if they're treating patients with vestibular or balanced neurology disorders, they have a portion of their clinic devoted to places where they have a Bosu ball, foam pad, cones, a Snellen and eye chart, various modalities and equipment that they can use. And in the home, the therapist has to bring it in themselves from their vehicle and so forth.
Yeah. And speaking to equipment, we live in the age of technology, right? The modern era, where there's so much of that getting integrated into practice, into care. And there's just different tools and apps. I know in some of the time I spent in the clinic, they used a lot of, I think it was a tool that kind of simulated like the metronome, right? Which was so that they could stay on pace when they're doing some of those movements with the head. But leading into my question is, are there things that you're using in the clinic from more of a technology assisted side from interventions, whether that's virtual reality or different things out in the field? Are there things that you are using or that you're finding success with in your outcomes, or things that you're interested to bring into your clinic and that other clinicians should be looking at as well?
Yeah, that's a great question. So in the vestibular world, much just like much of physical therapy world, a lot of our tools have to do with, well, the most specific tools is our brain and our hands. And sometimes we can pull in different modalities. So the one thing, like you mentioned, is a metronome. So when it comes to vestibular training, especially dealing with the vestibular ocular reflex, that has relays to the cerebellum, which is a part of the brain with smooth coordinated movement of agonists, antagonists, and things like that. So a metronome is something I'm using all the time. In terms of virtual reality, I'm not using too much of that myself, but I do know a lot of clinics do use it. And large, well-funded medical centers, for example, the University of Pittsburgh is a really good one. Johns Hopkins, the big ones, they have a dedicated center of excellence where they do have those virtual reality, the Oculus, the Apple Vision Pro, the Media Quest Virtualis. They have that equipment. And quite honestly, I've seen patients who've used that equipment and sometimes, need more therapy after that. So it really is just a tool. But I will say this, I do believe with the advent of AI and machine learning continuing to progress, I do think more of those tools are going to be on the horizon. And I've used Oculus myself, and it's a great tool. Before that, it was the Wii. But yeah, those are good tools to use, and I do see the future for it.
Yeah, no, I appreciate you answering that. And I want to spend a little bit more time here with you today, and I want to kind of shift our theme a little bit because you also have some other sessions at Rehab Summit. The other session being on post-op total hip arthroplasty precautions, dispelling myths and making informed decisions for clinicians. And I think that's going to be a great session as well. And I want to ask you, shortly while we have some more time left, what new techniques or innovations can professionals expect to learn to accelerate functional outcomes, following surgery in patients that have, had a total hip?
That's a great question, Evan. I am very passionate about physical therapy in general, and specifically, all topics related to neurology, vestibular system, as well as orthopedics. And I do have a bit of a subspecialty training in orthopedics with adult reconstruction, total joint. And through my 30 years of practice, I have had the privilege of kind of some what you would consider insider industry knowledge of going into the operating room and working with the surgeon, seeing patients in the clinic. If one can take away the most important adage when it comes to total hip post-op recovery, is less is more. So the way that the components are designed today contemporarily, they're constructed in such a way where you have a built-in constraint that really limits the patient's dislocation rate, whether you're doing an anterior, direct lateral, posterior approaches. Now, Evan, you've been, you're in the therapy world yourself. I mean, exercise is exercise is exercise. A therapist shouldn't have looked to reinvent the wheel. But when you do exercises, you want to specifically focus on muscles like the gluteus medius, the gluteus maximus, the quadricep muscle, the hamstring muscle. Very important. Additionally, you can never neglect the importance of proprioceptive and balance training with patients who've had total hip replacement. So again, like with the balance and vestibular, you narrow the width, you stand on different surfaces, you take away vision, you do things like that to really challenge their system. Now, lastly, I will say that nothing is going to be effective if you don't communicate and connect with the patient with a therapeutic alliance. So they have to trust you. They have to feel comfortable with your knowledge and with your skill set. Too many times we have patients who take a lot of medications for pain, a lot of which are opioids and muscle relaxants. My analogy is, if I'm going to be working with a patient who I need to develop their glute muscles or quad muscles, and they take a muscle relaxant, that's going to shut down their ability to contract the very muscle I'm trying to work. I'll tag that on going back to the vestibular. if someone has a medicine which is meclizine to quiet down the vestibular system, and then they get vestibular rehab, and we're telling them, go ahead and turn your head, and if they're taking a medicine to suppress that very system, it kind of runs counter to that. So in total hip, as in all therapy interventions, education is the next real big component, especially with pain science, pain neuroscience. So we need to educate our patients who've had total hips, to reframe how they're feeling their pain. Don't catastrophize it. Now, also comes the weight bearing. If a patient puts too much weight on their surgically repaired leg, sometimes they think that their hip is going to just fall apart or break. It's not going to happen. So our job is to demystify the physiology, but we have to talk to our patients in layman's terms, and that's a real big point of mine, is making somewhat of the complex anatomy physiology into digestible bites of information that the patient can come away with. And I like to pass that information on to my colleagues, and I look forward to doing that.
Yeah, no, that's wonderful. I couldn't have asked for a better answer. And I want to ask one more question, and this is from some of my personal experience. So I know I probably shared some of my past clinical life with you, Pat, but I did get to work as a PTA at a hospital setting, mostly in a total joint program, where they were seeing people post-op day 0. Obviously for PT evals, we were seeing them post-op day 1 to do treatments. I often saw each surgeon or physician, as you would say, is protocols, their weight bearing status restrictions, their activity restrictions can differ, right? Every surgeon may be a little different in how they approach that. Now, me as a PTA, I just follow what those protocols are. But as a PT, I can understand too, with that autonomy, is understanding how to make those unbiased decisions sometimes of what you feel is best for your patient, but also understanding what your surgeon or physician is asking from you. So how do you kind of navigate those so-called gray areas?
Yeah, that's a great question, and I'm sure you've been through this yourself in your clinical practice. But I will tell you that up until the point I actually went into the operating room and observed the surgeries personally, and then be in the clinic talking with the orthopedic surgeon, doing their evaluation, seeing the patient post-operatively, I was more than frightened. I was terrified to do something that went against their wishes or their protocol. But the one thing to remember is that protocol is just a guide, and movement precautions is just a guide. When a surgeon says no hip flexion greater than 60 because they may have a complicated hip revision, for some people who are maybe weak in their core, weak in their arms, they're not able to push themselves up from a bed or a chair or a couch without temporarily moving past that 60-degree limitation. Our job is to analyze whether that movement is safe with them, which 99% of the time it is. And then we allow them to do it, and we guide them through that, and we teach the family. Same thing with weight bearing. If there's a strict weight bearing precaution of no weight greater than 20 pounds when they put their foot on the ground. Now, the surgeons know we don't walk around with a scale to measure 20 pounds. So if they happen to put on 40 pounds or 50 pounds, the femur or the tibia is not going to shatter. It's not going to break. So again, now this is specific to total joint replacement. There are some nuances to those who have revisions or prior fractures, but you would compare this to those who've had a true fracture that's not a joint replacement. When their protocols are put in with non-weight bearing and things like that for the ankle, the foot, maybe the tibial plateau, you really want to pay attention to those weight bearing statuses. But when it comes to the total hip, total knee protocols, there is a little bit of wiggle room. Now, I am saying that on record, but you have to know the nuances of why there's wiggle room, and you can't arbitrarily just pass that on. You need to know. So I will share that at the summit, that information. And so to be unbiased, if you have any question, you always want to make sure you contact a physician, the physician assistant. If they're a fellowship program, contact the fellow. Most of the surgeons I talk to are very open. They like to have this conversation. And it's very lightning. So,
Yeah, Pat, thank you so much for sharing. I don't want to go too much deeper because obviously we want to save some for Rehab Summit,
Sure.
and I know you're going to have a lot more information to go dive into for each of these sessions. So super excited for that. Again, Rehab Summit's coming up very soon, but there's still time to register and pack your bags. It's in Orlando, Florida, from August 7th to 10th. Today we do have a special promo code for you available from Pat. It's save $100 off the in-person registration. That's using the code RS24PT at checkout. And you can also register at the link there, rehab.pesi.com/Tino RHS24. Or if you scan the QR code in the top left corner of your screen, that'll take you to the registration page. Pat, super excited to see you in Orlando. Excited to get to meet you in person. Obviously, myself, we do a lot of this virtual world living nowadays, so it's fun to be able to get in front of some of the speakers that I get to work with, but then also some of the clinicians that are attending our trainings, and just to kind of connect. Obviously, learn more about what's the future of rehab. So super excited.